the Vasculitis Patient-Powered Research Network was started 5 years ago as a collaboration between lots of different stakeholders. And so when Joyce said I helped create it, yes, I was a part of a much bigger team of people coming together. And one of the novel things about the VPPRN is that we brought patients into the conversation and the development of research protocols at the very beginning stages, from research prioritization to collecting research ideas. So our mission and our vision, we were seeking to transform how clinical research in vasculitis is conducted by directly engaging investigators, care providers, and health systems to develop research methods to electronically collect health records and patient-reported data on a large number of patients with various forms of vasculitis. So really what we wanted to do is we wanted to create a research network that could be done online that is similar to a registry where we're collecting longitudinal data, but we wanted our patient voice to be imbued in every aspect of that. And we really evolved out of the Vasculitis Clinical Research Consortium, which you may be familiar with if you're on their patient contact registry. We always used to say we were kind of the VCRC Patient Contact Registry 2.0. We collect more data and patient-reported outcomes that the VCRC Patient Contact Registry does not. And then we were, again, the Rare Disease Clinical Research Consortium and Rare Disease Clinical Research Network was a part of that group at the table when we were first formulating, and then of course the Vasculitis Foundation. So all of these groups came together and said, how can we collaboratively do research in a different way and engage patients and patient voice in all that we do? So this is really, the VPPRN is really a product of the power of partnership and collaboration. So we brought together existing vasculitis entities like the VCRC and the RDCRN, as well as PCORNet, which is a larger research network of other patient-powered research networks and clinical data research networks that were studying different disease areas, but where we could have cross-fertilization of our research efforts. Then we brought in patient advocacy groups, and as well as our patient partners, our clinical investigators, and that's really what created the infrastructure and the basis for our research network. So these are, kind of the data resources that we have. We collect electronic health records, physician-reported data, patient-reported data, and qualitative surveys. We have scientific partners, patient partners, other stakeholders, and industry partners. And we pull data from clinical data research networks, health plan research networks, other patient-powered research networks, and then the Vasculitis Clinical Research Consortium. And there you can see it bigger. This is the examples of data we collect. We collect baseline data, self-reporting data. So if you have a flare, we want to track that over time. So now that since our launch in 2014, we have 5 years of data on some of our participants, and we can track, for 3 years in a row, you have a flare at this particular time of year, and we can track that. And now this data is becoming interesting for not only investigators, but for patients themselves to look back and see how their disease has changed. And as long as they're reporting, we kind of have this nice history of, disease activity. So these are our current studies. Several of them, as you can see, the manuscripts have been accepted and published. AAVPRO, VASWork, where we looked at work disability and limitations among patients with vasculitis. The computable phenotypes. Our vasculitis pregnancy registry is still open and enrolling participants. We are also translating that into 6 different languages now, and we're almost completed with the translation of 3 of them. So it's exciting. We'll be able to launch those soon, and so it will be in other languages as well, not just English. The patient involvement in medical research, this was our most recent publication. It was published in January of this year. And then our health core demonstration project and journey to diagnosis, which I will discuss in a little bit more detail coming up, because it's one of our more exciting projects that came from our patient. It was a suggested research question from one of our patient partners. So. Then the Pathways to Diagnosis project, I will also talk a little bit more about that. It's been a common theme today that I've heard time and time again, early diagnosis. What are some of the keys to better treatments? Early diagnosis. How do we avoid other complications? Early diagnosis. And yet we seem to, the progression towards an earlier diagnosis is not moving at the speed we'd like to see it. So the Pathways to Diagnosis project is a novel way to address this kind of lack in movement. So then our Healthy Mind, Healthy You study. This is a cross-patient-powered research network study. So we're doing this with lots of other large research networks where we're looking at mindfulness and its impact on patients' lives. And so that will be launching soon, which is really exciting because it's been a lot of years in the making. So we're ready to have it launched. Then our choice demonstration study, Veritas, where we're looking to understand patients' preferences for glucocorticoid steroids and dosing. And the hope is that some of these projects will lead to much larger and additional research in the future. So that's exciting. And then the nasal microbiome, that one we're still working on. It's in its very early stages of development. Vasculitis, where we'll be looking at cutaneous manifestations of vasculitis, and then also numeric ability in vasculitis. So examining literacy, numeracy, and patient activation to identify patients' knowledge of numeracy and reading your own labs, et cetera, and then identifying those gaps so that organizations like the Vasculitis Foundation can supplement with programming that can be helpful to patients, so you have the ability to engage more in your own health and your own treatment. So that's where we go. So I wanted to talk today a little bit about the Journey to Diagnosis study. So we had a poster at the 2018 ACR, and we will also have a poster at the ANCA workshop this coming April. In fact, it's about 3 weeks away in Philadelphia. So the objectives of the study, it came from, we collect research questions from all of our participants. You log into your portal, you can suggest a research question. We then distill those research questions and put them into categories, right? Okay, so this one goes over here in treatment, and this is here in diagnosing, and by far and large, the most important research question, it seemed, to patients, because we got it again and again and again and again, was identifying why there are delays in diagnosis and how do we address them. And so we decided to take it on and said, okay, let's kind of figure it out from our own network and from our engaged patient population. What does that look like? Let's see first what our patients felt were the causes of a delay in diagnosis, because it's our patients that experience this, that walked this for years. So we looked at the diagnostic delays, and it was a two-stage study. So the first was a qualitative survey. We left it very open-ended because we really did just want to collect and understand how patients thought about their journey to diagnosis and what they felt were the causes of their delay and their impact. And so we collected all of a qualitative survey and collated the responses, coded the responses, and kind of looked at those factors that we could find themes with. And then we divided them into patient-related factors as well as health-related factors. And that's how we were able to develop our more extensive survey, which was our stage 2 survey. So then that survey was disseminated based on the findings from survey 1, from the qualitative survey. And then we had our multilinear regression analysis, and we were able to kind of get a better picture of what factors impact a delay in diagnosis. So I just wanted to toss these up to here and give you some perspective and see how many of you relate to this experience. So the mean time to diagnosis of vasculitis And we enrolled all of the vasculitides. It was open to every form of vasculitis. So when I say this is, writ large, in the larger group umbrella of vasculitis, it was 3.3 years to 7. I mean, just by a show of hands, how many people can relate to that experience, that real delay in diagnosis? Yeah, and this is, we want to address this issue, as do most care providers, researchers, investigators, patients, industry. We all want to address this issue, but we needed some more data on what we know from a patient perspective to understand were those delays in diagnosis. So really what we found were that 73% were misdiagnosed. They were misdiagnosed initially. Did anyone here have a misdiagnosis? Did it diagnose you with something else first? Yeah. What was interesting was that in the survey itself, and it's not here, we saw that we gave the option. Did you have 1 misdiagnosis, 2, 3, up to 7+? And there were, it's almost laughable. There were lots of patients, and I don't remember off the top of my head the percentage, that had more than 5 misdiagnoses. They had to keep coming back and advocating for themselves because they knew that was not the issue. And so I thought that was a really interesting and very impactful point of data where we're like 73% of our patient population is misdiagnosed. We need to address this. So then 40% of the diagnoses were made in a hospital setting, and 35% were inpatient, and 5% were emergency room. So it got to the point where they needed to be in an emergency room, and that is where the diagnosis was made. So we needed to improve. So we use this as more evidence that we need to address in different and novel ways the delays in diagnosis. Which leads us to pathways to diagnosis, pathways to diagnosis kind of came out of, not out of Journey, but certainly launched from Journey. So the objective of this project was to identify diagnostic pathways or algorithms in large healthcare administrative databases that predict specific or preliminary diagnosis that would lead to targeted screening and referral. And then prospectively apply these algorithms within a health system to accelerate accurate diagnosis. So what all that means is we were going to take something that is these algorithms, right, and machine learning that is commonly used in other spaces, like Google or Amazon. Amazon Prime knows what I want to buy before I know I want to buy it. How do they do that? Well, they take all of this unstructured data and they pull it in, and then they put it into an algorithm that very accurately tells me what I want to buy based on my purchases, based on my searches, based on comments that I've made on other items. And they're able to serve me exactly what I want to buy, right? So what we thought was that let's apply this in a novel way to undiagnosed patients. So we developed the computable phenotypes to identify patients. Now let's do this with undiagnosed patients. So aim 1 was to identify the diagnostic algorithms for 2 autoimmune diseases. So we were partnering with another patient-powered research network, AR Power. They look at rheumatoid arthritis, and so we chose vasculitis and spondyloarthritis to be our first tests here. So in a large healthcare system, databases using predictive analytic and machine learning techniques to calculate the risk of having a specific autoimmune disease. So now we're taking all of that unstructured health data in this health system, and instead of requiring the physicians themselves to put the pieces together, right, to figure it out, we're taking the unstructured data and saying, hey, we've developed these algorithms for diagnosis, right? We know these factors kind of across the board are gonna give you a pretty good predictor that you have a specific, autoimmune disease. So then we're going to go to AIM 2, and we're going to test the comparative effectiveness of applying those predictive analytic models in a learning healthcare system to calculate patients' predicted probability of having the condition of interest and notifying the appropriate physician to enact change in evaluation and care and improve a patient's diagnostic journey. So this idea that it is all in the hands of your physician or primary care or expert, whoever you are seeing, it may be that the algorithm will run. So here we are, we're training the model, we have these predictive analytics models. The model will run itself in the data. Then for your physician, it'll little ping, there'll be a little note that pops up that says, hey, this patient may have spondyloarthritis. This patient, you might want to test for, you might want to do an ANCA test on this particular patient. So it takes some of that work out of, the onus is not all on the physician to have an awareness about rare diseases, because it's not just vasculitis, it's all of the vasculitides therein too. And so it's saying you don't need to have an expertise in this. You don't need to have, it reduces the amount of awareness that needs to be had by physicians and allows the data to speak for itself based on these algorithms. So then the hope is that our algorithms will provide a faster diagnosis than the traditional model of being dependent on the physician to diagnose.
Excuse me, I don't have a question, but I do have an anecdote
Okay.
in relation to what you've been talking about. My wife had been experiencing a problem for about a year, seeing an eye, nose, and throat doctor, excuse me. And they didn't come anywhere close to it. So I finally got to the family physician, and he said, well, I don't know what's wrong with her. Maybe it's valley fever, maybe it's pneumonia, so forth. So he was going down this slow path. We'll put her on this dose of this, and then we'll go to that dose of that. Time's passing by, and you know how the disease moves forward, regardless of a doctor's schedule.
Right.
So my daughters got together with the symptoms, you know, of the problems with the sinuses, with the ear infection, with the lung nodule. They went on to Google, and not 3.3 years, about 3.3 minutes together, they came up with a diagnosis. I took it into the doctor, and he said, no, it wouldn't be that, because, you know, the so-and-so doesn't show up. So he just kind of passed it by, even with that recommendation. But I'm saying, it looks like it's pretty easy, at least in this case it was, to come up with a diagnosis for somebody to take a fresh look at it, maybe who didn't, you know, who wasn't locked up in the medical system the way you have to go from step to step, taking months after month. And so she would have probably wouldn't have made it if they hadn't done that.
That's really incredible, but that's kind of the hope, right? That there are different and novel ways we can use large unstructured data that we have, you know, in healthcare systems that we can utilize to our advantage to be able to, you know, to be able to diagnose patients faster, or at least give the suggestion for further testing to indicate a specific form of vasculitis. And that's one of our challenges for the Vasculitis Foundation. It's extremely important for all of us, spreading awareness, and not just awareness among the general population, but you know, primarily among physicians, so that there is, you know, this awareness of vasculitis. But this takes, again, as I said earlier, it takes the onus off of the physicians. So it's kind of a new way of looking at, not all of it, of course, but for those that may not be familiar with vasculitis, for those that we haven't reached with our awareness campaigns, if this can help them get to a diagnosis for a patient faster, that's the hope. And so it's used in the same machine learning and predictive analytics models are used in every other industry and field. So we felt compelled to try it in our own space, especially in a space for rare disease and where the time to diagnosis is unacceptably slow. So.
Your number about 72%. That's patient reported?
Yes.
I sort of struggled with this concept of misdiagnosis, because I mean, there were things that turned out to be EGPA way after the fact, but before they were EGPA, they really were a sudden sensory neural hearing loss. That's true. They really were chronic sinusitis. That wasn't a
Yes.
lie. That wasn't a misdiagnosis. Those things were
Accurate
correct. They were
diagnosis,
sort of
but
not the whole picture. So do you know how people were thinking about it when they said I was misdiagnosed? I mean, was it that people were really getting it wrong, or they just weren't getting the whole picture? Do you have any sense?
So I think it was, no, and that's actually a really good point. I mean, I think that's kind of a challenge in some of the data, is that there wasn't an accurate way to say whether or not patients were thinking about it as misdiagnosed, like this was a incorrect diagnosis, versus it was a correct diagnosis, it just wasn't the source, right? So this is absolutely a correct diagnosis, but it wasn't the diagnosis of EGPA, for example. So I think that's a limitation for sure. But as I had mentioned, we have patient partners that work with us on all aspects of development, from prioritization to actually writing the research questions. And so it was one where in our working groups, we had several people discuss that, but felt that this was probably the best methodology to get at the idea of a misdiagnosis. And that was certainly shared in the phase 1 survey that was more qualitative, and it was open text. And most from that survey, and I can speak to at least what I saw when coding it, was that people were misdiagnosed as a wrong diagnosis, not confusing other diagnoses as incorrect when they really were correct, but it just wasn't the source. So.
I think the problem with that is you're not going to know the full diagnoses until you get more symptoms and you collect the symptoms. And so I think it's the duty of the vasculitis group and the physicians to take a really good oral history. And then the blood work should help show some of, I know Jody has, she has vascular stress vasculitis. And so the blood report is so very important to us. But I think that they just, I think they're sharp doctors. They should be able to start thinking in terms of what could this be. So I think you've got a great idea in going backwards after that. That was a smart thing to do.
Thanks. That's our hope. We'll see. Okay, so I have a couple of housekeeping things, and then we'll let everybody get up and have dessert. So Ed wanted me to share that we're taking pictures with the Vasculitis Awareness Month poster right outside, and if you take your picture with the poster, you get 25% off all of the store merchandise, or you put into a raffle for 25% off all of the store merchandise. So, which is great, but really we want to promote Vasculitis Awareness Month, and so this is one of our great opportunities where we can take pictures of all of us engaging and enjoying the educational programs of the Vasculitis Foundation, so that in May, when it's Vasculitis Awareness Month, we can push that out to a broader community and encourage others to engage and to work with the Vasculitis Foundation. So thank you all.